Hello, everyone. Welcome, and thank you so much for joining us today for Healthy Women's Advancing Employee Wellness and Access for Women Living with Obesity. We're so glad you're here. My name is Katie Collins. I'm a vice president at G2G Consulting, and I've had the pleasure of working with Healthy Women on a variety of different policy areas, including this one. So thank you so much for having me. Before we get started, I'd like to say a special thank you to the Alliance for Women's Health and Prevention's Every Body Covered campaign for their financial support for today's webinar. And thanks to all of you for joining us today to discuss the impact of obesity on women and the importance of access to coverage, especially employer-sponsored coverage for the full continuum of obesity care. To start us off, I'd like to introduce Beth Battaglino, Healthy Women's President and CEO, for her opening remarks. Beth?
Thanks so much, Katie, and thank you to our audience for tuning in to our conversation on advancing employee wellness and access for women living with obesity. I'm Beth Battaglino, President and CEO of Healthy Women. Healthy Women is the leading independent nonprofit health information source for women. And for more than 35 years, we have been dedicated to educating midlife women so that they can make informed decisions and advocate for themselves and prioritize their health and wellness. At Healthy Women, we know our voices are always stronger together. Through our many campaigns, we have amplified the voices of real women. And for the past few years, a major focus of Healthy Women has been on educating women and healthcare providers about the intersection of obesity and other health conditions. And there are a lot, as you'll hear about in a moment. In partnership with the Alliance for Women's Health and Prevention, we are so pleased to be part of the Every Body Covered campaign, an important and needed platform to continue advancing wellness and access for women living with obesity. Thank you all again for being here. Katie, back to you.
Oh, thank you so much, Beth. Before we get started with our discussion and presentations, I'd like to introduce some recorded remarks from Dr. Millicent Gorham, the CEO of the Alliance for Women's Health and Prevention. Dr. Gorham.
Hello, everyone, and a warm welcome to today's webinar hosted by the Alliance for Women's Health and Prevention and Healthy Women. I am the magnificent, marvelous, magnanimous Millicent Gorham, and I serve as the CEO of the Alliance for Women's Health and Prevention, or AWHP, a nonpartisan, nonprofit organization that advocates for policies that promote preventive health care for all women and girls. I'm thrilled that you could join us. Today's discussion is focused on advancing access to comprehensive obesity care coverage. We will hear about the experiences of women living with obesity, the current obesity care coverage landscape, and how advocates can take action to improve access to comprehensive obesity care. We know that obesity is a chronic disease and a woman's health issue. It is associated with over 200 other health conditions that impact women across the lifespan, including fertility issues, breast and ovarian cancer, depression, and more. So if you care about maternal health, if you care about breast cancer, or if you care about mental health, for instance, then you need to care about obesity too. That's why in February of this year, AWHP launched the Every Body Covered campaign, the first campaign that is activating women to raise their voices and call for obesity care to be covered just like any other chronic disease. We are grateful to have the support of 20 partner organizations who are leading voices across the healthcare advocacy space, including Healthy Women, our co-host for today's discussion. I encourage you all to visit everybodycovered.org, To learn more about our campaign and get involved in advocating for coverage. Be sure to follow the campaign on social media to stay connected to important conversations like the one taking place today. I want to thank you all again for joining us. I will now pop things over to Katie Collins, our fabulous discussion moderator.
Well, thank you, Dr. Gorham. And to kick us off for our first presentation, I'm pleased to introduce Dr. Priya Jaisinghani. She's an endocrinologist and certified obesity medicine specialist and a clinical assistant professor at NYU's Grossman School of Medicine. She'll be discussing the science of obesity and its impact on women. So Priya, thank you so much for being here, and over to you.
Absolutely. Thank you so much for the introduction, and it's truly an honor to be here. And I'm just going to give a short introduction about discussing obesity as a chronic and complicated disease, why that's important, and what we need to be on the lookout for. So without further ado, let's get started. So why are we talking about obesity as a disease? So we can start with the first slide. So the Global Burden of Disease Study reports that overweight and obesity are the fourth leading risk for global deaths. That accounts for more than 4.7 million adult deaths each year. So how does this affect us here in the United States? So let's take a look at the United States and the prevalence of obesity according to the data from the CDC, or the Center for Disease Control and Prevention. So here we can see that no state or territory has a prevalence of obesity less than 20%. Only the District of Columbia has about 20 to 25% obesity prevalence. There are about 6 states that are between 25 to 30% of obesity prevalence, and 3 states have a prevalence of obesity greater than 40%. The remaining states have a prevalence between greater than 30% to less than 40%. So what's startling here is that in just 10 years, we have had drastic changes in the prevalence of obesity. Just 10 years ago, no state had an adult obesity prevalence at or above 35%. So that is a very big change. We can go to the next slide. Here we can see that, the prevalence of obesity and severe obesity has increased significantly, and that's across adult men and women, as we can see here in the graph, between this time frame. And according to NHANES data, the U.S. obesity prevalence was about 42% in 2017 to 2020. And it's estimated by 2030 that prevalence will be on the rise to about 50%. And according to a study, we saw that the estimated annual medical cost of obesity in the United States was nearly $173 billion in 2019 dollars. Okay, so we know that the adult obesity prevalence remains high, and it's getting higher. And this really highlights our need to recognize obesity as a disease early and also to treat it. So we can go to the next slide. So how do we really identify individuals living with obesity? So the CDC uses body mass index, or BMI, which is a person's weight in kilograms divided by the square of their height in meters, to measure obesity. So BMI greater than 25 is categorized as overweight, and BMI greater than 30 is categorized as obese. So while BMI is being used as a population tool really to estimate risk, it can be used as an initial tool to screen for obesity. However, we have to remember that it certainly has its limitations, right? And we can consider that sometimes it can be seen as an oversimplified tool. Nonetheless, it's still important as an initial screening tool. So BMI, we have to remember, does not have the ability to distinguish weight associated with muscle versus fat. It does not distinguish body fat distribution as well, which we know is a important determinant of metabolic risk. So remember, when we talk about body fat distribution, we know that increased visceral fat predicts the development of metabolic syndromes, such as type 2 diabetes or even cardiovascular disease. And we also know that BMI does not account for age, sex, or ethnic variations as well. So there are other tools that we can use in our armamentarium to diagnose obesity, but this is a initial screening tool that we see across many doctors' offices and clinics to kind of assess for risk with living with overweight and obesity. So we can go to the next slide. So along with policy statements, that have kind of commented on the limitations of BMI, there have also been proposals from major endocrine organizations, such as ACE, or the American Association for Clinical Endocrinologists, for new diagnostic terminology for obesity. And they were proposing to call it adiposity-based chronic disease, or ABCD, because obesity is not about the weight itself, but it's about also the health risks it causes due to the effects of excess weight or adipose tissue. So ABCD can result due to a complex combination of biological factors, such as genetics, hormones, along with a variety of lifestyle factors, environmental factors that can produce dysfunctionally positive energy balance, leading to an accumulation of fat tissue. And as it was mentioned prior in this presentation, obesity is linked to over 200 diseases, and we can see some of them listed here. So type 2 diabetes, heart disease, high cholesterol, high blood pressure are just a few of those which are associated with obesity or living with overweight. So we can go to the next slide. So now we really look to identify individuals living with overweight and obesity and what comorbidities or coexisting conditions related to weight that they may have. So when these comorbidities are identified, we are now shifting our paradigm in the medical field from treating weight last to now treating it first. So why is that? Because weight-related conditions may be improved or even reversed or in remission through weight management. So we really try to focus on treating the weight first as opposed to last to help better some of those associated conditions. Okay, so we can go to the next slide. So, once we have an individual who we've identified as living with overweight or obesity, we can then screen them for weight-related conditions or comorbidities. Or vice versa. If we have an individual who we think has a weight-related condition, we may screen them to see if they're living with overweight or obesity. When you're in a doctor's office, it's also important to make sure that you have a conversation with your doctor about other contributing factors that can be leading to overweight or obesity. Some of these contributing factors can include, for example, a family history of obesity, your environment, maybe a lack of access to certain foods, lack of a safe space to exercise, your sleeping habits, whether that's quality or quantity of sleep, medications that you're on. Believe it or not, there are medications that can actually contribute to weight gain. And it's also very important to make sure you have a conversation to make sure you're screened for underlying eating disorders and other disorders, right? Such as hormonal disorders, whether that's hypothyroidism, PCOS, insulin resistance, diabetes, or others. So we can go to the next slide. So today, what is the expectation in terms of treatments for living with overweight and obesity? How do we treat individuals living with overweight or obesity? So there are many different realms of treatment spanning across lifestyle, medications, and surgical interventions. So lifestyle changes should always be a central part of any weight management regimen, right? Whether that's directed by you or directed through a professional. I believe it's really important to have a holistic approach when it comes to that and really set up a good multidisciplinary team. What do we mean by that? Having individuals from multiple disciplines that can actually contribute to different aspects of living with overweight or obesity, because it's a very complicated disease, and it's also chronic and it can relapse. So it's best to have a multi-pronged approach when treating diseases such as obesity. So it's very important to have, for example, a nutritionist on board, a fitness expert, a psychologist or psychiatrist, and a physician who is either well-versed in weight management and possibly obesity medicine certified, or seeing someone such as an endocrinologist, right? So we have lifestyle changes that we went over, then we have medication therapy. So current guidelines in medicine recommend that individuals who have attempted lifestyle modifications or improvements and continue to have a BMI or a body mass index greater than 30 or 27 with one weight-related medical condition are eligible for weight loss medication treatment, okay? And we call those anti-obesity medications, or AOMs. So that's also a recommendation that's made alongside lifestyle changes if you're applicable. The other category of treatments that we have are surgical interventions. So recently, actually, we saw that there was a change in the criteria for metabolic surgery eligibility. And in 2022, the American Society of Metabolic and Bariatric Surgery lowered the eligibility cutoff. So now it's a BMI greater than 35 or a BMI greater than 30 with a weight-related medical condition. So those would be the new cutoffs. The reason I'm discussing this today is because I want you all to be aware of the therapies that are available to you. And it's important to have the conversation with your physician about all potential options so you're aware about what options are available to you if you're going to seek treatment. It's not necessary that you're seeking only one avenue of these treatment options. You could be seeking a combination of these avenues of treatment options. And that's why it's really important to have that discussion with your doctor. It's also important to remember that the goal is not only weight loss, but it's weight maintenance. And another goal is also to reverse or halt the progression of some of the metabolic abnormalities or weight-related conditions that we can see in this disease state. So you should be sure to speak to your doctor about lifestyle, medical, and surgical treatment options. You should select a therapy or a combination of therapies which are individualized to you. And remember that when treating complex diseases such as obesity, you want to have slow and gradual changes, and this will give you greater chances of success with combating a disease such as obesity and its related conditions. So this was a quick overview of obesity as a disease state, some of the common associations that we can see as weight-related comorbidities, and some of the treatment care options that we have available today.
Thank you so much, Priya. Really appreciate that really thorough background on the science of obesity and how it impacts women and what some of the treatments are. I'm going to turn it over to Dr. Shieva Ghofrany. She is both a practicing OB-GYN and co-founder of Tribe Called V, and she's here to discuss her own personal journey as a woman living with obesity. And we're so pleased to have her here. So Shieva, over to you.
Thank you. Thank you, everyone. Thank you, Katie, for that nice, warm introduction. And thank you to everyone who's hosted this great webinar. I mean, this is a story and a subject that I hate to say is near and dear to my heart. It's very near to my heart. It's increasingly dear to my heart because I feel that I'm finally able to find the tools through surgery and medication. And as Dr. Jaisinghani suggested, a combination of approaches. So it's becoming dearer to my heart. That said, as I say this kind of jokingly but seriously, as an OB-GYN, I've been honored and cursed in a way with this what's what of gynecological health myself. So I've been through endometriosis. I've had HPV, which I speak about very openly and transparently to debunk the anxiety and myths about, frankly, all of these things. I've had multiple pregnancy losses. I had ovarian cancer, and I had weight loss surgery myself. And that's kind of just an overview and a smattering of some of the things I've experienced. And the benefit has been that I've learned from my patients how to manage a lot of these things, and then I've been able to teach my patients. I think, probably like many of you, my journey into my weight issues started at a young age. I was raised actually by two immigrant physicians from Iran. My father was kind of one of the original in the early 70s physicians who knew about weight and about health. He was not one of the doctors in the doctor's lounge eating donuts every day. He was the one eating fresh fruits, eating healthily, really championing it, not smoking. He was exercising, which was wonderful. He had great intentions. But what that translated into was a culture, a little bit of shame, because the way he transmitted that information to my sister and I was very much one of, why would you want another piece of pizza? How could you want to eat another cheeseburger, right? Things where, as a young girl, as early as I remember, probably 6 or 7, wanting the food, truly loving the food, and yet never really being able to enjoy the food because there was a constant level of shame and anxiety attached to, there's something wrong with me that I want it. And that led, like many of us, I think, to eating kind of behind closed doors. So, out in the open, I wouldn't necessarily eat very much, but behind closed doors, I would relish my time alone with food as comfort. And from a young age, when I started to do that, I now laugh because I look back and say I would cut off my toes to be the weight that I was when I thought I was heavy in my teens and 20s. I see people kind of shaking their heads, right? Back then, in my teens and 20s, I was hovering between 130s to 150s, which was admittedly more than my height and my BMI should have been at 5'3". But again, I would have been thrilled with that in my older years. But I started doing professional diets. I remember going to Diet Center, if anyone remembers that, in the 70s and 80s, to there was another one called MetaFast that Oprah kind of made very popular, like OptiFast. These were like very specific, really low calorie diets that in the 70s and 80s we were taught was the way to lose weight. Major calorie restriction, aerobic exercise, and frankly, a culture of shame around food, right? And yet food was also celebrated. That was the time where fast food was really starting to grow. We had no knowledge of the nutrition, or at least we had knowledge, but there were a lot of scientific snafus where people, as we know, were championing sugar and really maligning fat. So we were taught that all of those packaged goods, I remember as a resident eating packaged food that we were counting as Weight Watchers points. And my co-residents and I learned that we could eat, I think, 3 chalupas and several Weight Watchers desserts, and that could be a nutritious day of eating. And so that started my journey of yo-yo dieting. I could stick with a diet like nobody's business. My friends and family were always amazed. If Shieva was on a diet, she would not eat a morsel of food off of her regimen. I would lose 20 pounds within a month or two. And then, as we can guess, I would gain it right back without realizing the detrimental effects on my metabolism. So that was through my teens, early 20s, until I became a resident. Many of you might know that when you were a resident, especially in OB-GYN, and especially back in the 90s and early 2000s, we were actually working about 110 hours a week. So I started residency at 29. I was already about 170 pounds and then quickly jumped to 200 by 6 months into my resident year. I wasn't sleeping. I was stressed. I was, believe it or not, doing Weight Watchers, but I was going up and down about 5 pounds less, 7 pounds more, 6 pounds less, 8 pounds more. And that continued up until age 34. So for a 5-year span, I went from 170 up to 250 pounds. I had had 2 miscarriages during that period of time and then birthed my first child. And as Dr. Jaisinghani can guess and can tell everyone, the complications surrounding my pregnancy really were almost 100% exclusively due to my weight. And I say that now without self-flagellation, without guilt, but really with the knowledge that it's okay that that happened. I was doing the best with what I could at the time, but now I know better. The hard part as a physician is trying to translate that into conversations with our patients without leading to shame. But so until 34, I kind of stuck with that 250 pounds. And at that point, I was so exhausted. I was working full time. I really wanted a second child because I wanted my first child to have a sibling. So I embarked on trying to get pregnant again and ended up having 4 more miscarriages and then another baby. So by the age of 38, I had 8 miscarriages. I had endometriosis. Sorry, I had 8 pregnancies, 6 miscarriages, 2 babies, endometriosis, a really challenging vaginal birth, a very challenging but easier C-section. And I was just exhausted. And I remember one day in my office, one of my patients came in, and I was very transparent about my weight. I was not someone who ever felt that I should kind of hide it. I couldn't hide it. And I also didn't feel like I should continue with a lot of the rhetoric that I heard other people say, like, I'm really not eating that much. I don't understand why I'm gaining weight. I wasn't necessarily eating that much, but at one clip, I could put 1,500 calories down. I was drinking, venti lattes with sugar in them and a donut. Like, I knew it was poor quality food, but I just couldn't do anything differently at the time. And a patient came in. She had suddenly lost a lot of weight. She looked not only lean, but she also was just so much healthier. Her blood pressure had gone down. Her diabetes had gone away, all of the parameters. And she was one of the first patients that I saw who had just done the lap band. And I said to her, "Oh my God, you look amazing. I'm so excited for you. I wish I could do it." And it was one of the first times where I really realized how overweight I was, even though I hadn't been in denial, when she said to me, "Shieva, you should absolutely consider doing surgery." And it was literally like overnight, that light bulb went off. And I thought, I'd always still thought of myself as the person I was at 130 to 150, which was admittedly heavy. So the good news was when I was more than 100 pounds heavier than that, I didn't hate myself that much more. The bad news is that had I accepted myself at 130 to 150, I probably wouldn't have allowed myself to have that slippery slope. So one of the messages I would love to kind of put out there to everyone, especially younger women, is the self-flagellation that occurs about our food and our eating habits is probably what leads us down that slope of gaining even more weight. If we could all at once love food and truly enjoy food without the guilt and anxiety and shame attached to it, we would probably just eat it as it's there and not feel like we had to hoard it or hide it or any of those things. That's easier said than done, obviously. But so I initially started thinking I was going to do gastric band, the lap band, which I think is not done as much anymore as we had done in the past. But when I went to see my surgeon, he was wonderful. He was very knowledgeable, but also deeply kind and led with such a feeling of support. And he made it clear to me that if I did the band, the odds were I was going to lose some weight, but this was going to be a lifelong thing. And he really nudged me to kind of consider what at the time was gastric bypass. They did not have the gastric sleeve. So I was about to be 40. I was done having children, or so I thought. This was now in 2009. And I did, within 1 month, I decided I was going to do it. I got my therapy done because they needed you to see a psychologist. I needed to see the GI doctor. I got every single test. I told my partners in my practice that I was going to do it. I did my gastric bypass, and 1 week to the day, I was back in my office, and I shed about 80 pounds within 4 months, which of course felt glorious at the time, but was also done in a way that set me up for some problems in the future because there was no regard for weight training, for really making sure that I was doing some of the other nutritional things that we really know now. Now we've learned a lot. I was certainly very appropriate about sticking with healthier eating. I wasn't eating small quantities of poor quality food, but I was not exercising outside of some level of aerobics to the degree that I should have to build muscle. And then 8 months later, I got pregnant by surprise, despite being a fairly knowledgeable gynecologist. And the irony was that that is now my beautiful, healthy, almost 14-year-old. And when I went to see my surgeon, who kind of jokingly said, "You really weren't supposed to get pregnant. I thought you were done." And I said, "I know, I thought I was done, but guess what? This is going to be my healthiest pregnancy." And true to form, that was one more example for my patients that weight really does have such an impact. And we've known this, but they finally saw the living embodiment. All of my patients had known my journey. I shared it very freely with them. But my 2 prior pregnancies were really challenging, again, because of diabetes, well, pre-diabetes, I should say, because of hypertension, because of some other complications that occurred. Whereas at 40, where I should have had the most challenging pregnancy, I was 80 pounds leaner. And that pregnancy was actually my healthiest. All of my testing, all of my blood pressure issues, everything was better. And I felt more vital. So flash forward, I ended up having ovarian cancer 6 years later. And my weight after my gastric bypass stayed largely steady. I would fluctuate about 10 pounds, but I stayed mostly within a range that I felt comfortable with. When I got ovarian cancer and chemotherapy, I went back up another 20 or 30 pounds, which really frightened me at that point. I did not want to get back to what had happened in the past. And that's when I really started learning more. And with the help of a lot of, thankfully, endocrinologists, we learned that weight training, that extreme calorie restriction was not necessarily the healthiest way to kind of proceed with weight. And then we had the rise of medications like Ozempic. Now I'm at the point where, with a very small dose of Ozempic, with weight training, with really aggressively eating protein, I'm able to maintain a weight that I'm comfortable with. I've accepted that I'll never be skinny, but I don't want to be skinny anymore. And so one of the things that I think has been the most helpful for my patients to see in this trajectory, and so many of them have been with me through the last 20 years, is that we don't want to just calorie restrict. We don't want to self-flagellate. We don't, to Dr. Jaisinghani's point, want to only adopt one form of weight loss. Surgery, I think, is a wonderful tool and should not be avoided at all costs. Medications, wonderful tools, should not be avoided at all costs. But if they are not combined with some level of mindset and really aggressively understanding nutrition, weight training, and the value of protein, then no one will be successful. And I think that's where we're getting better as a medical community, but we're still missing out a little bit because we need a lot more multidisciplinary teaching for our patients. So I would say to all of my patients who ask every single day, do you think I have to go on medication? Do I have to do surgery? And the answer is no. But the honest truth is, our world is so challenging right now with the stresses that are happening, with the food availability, with the shame that's attached. So I think that because of all of these issues, to be able to embark on a weight loss mission that is lifelong without some external help feels really overwhelming. So I implore people to really accept and understand that if they need help in the form of medication or surgery and other forms as well, it's really okay. And they shouldn't feel ashamed. They shouldn't feel guilty. They shouldn't feel like they've failed. So that's why I'm very open about my story. I never want to kind of pretend or behave as if I've done this on my own. I've done it on my own to the degree that I'm proud of myself for what I've adopted and how I've made lifestyle changes. But I'm happy to say that I've received all the help I can through the medical community. So I hope that the story and just understanding that we all really struggle with this, and it's something that is part of our world. It's increasing, as Dr. Jaisinghani pointed out. I really liked the comment you had made, and I'd never heard that term, dysfunctional positive energy balance. I feel like that paints it in such a more beautiful light. I have an incredibly dysfunctional positive energy balance that I am cautiously optimistic that I'll be able to wrangle with the help of other aspects that we have in our medical world. So thank you for the opportunity to talk about my story, and I hope it helps even one person just feel better about their experience.
Well, it's helped me. There's your one person.
Yeah.
Thank you so much for sharing your story. I'm almost speechless with you thinking about everything you've gone through, and so much of that I know I can personally identify with, from your stories about, being a teenager through some of your experiences with pregnancy. I mean, I feel like I was right there with you. I'd love to have a cup of coffee and keep talking. That was so interesting. Thank you so much for being so open with your story. Our last panelist I'm excited to introduce is Deb Gordon. She is the co-founder and CEO of Consumer Health Advocacy, and she's going to be discussing the implications of a lack of insurance coverage for people living with obesity. So Deb, thanks so much for being here, and I'm going to turn it over to you.
Thank you so much. And thanks to all of you for having me and for the wonderful talks that have gone on already. I'm also learning a lot and was so moved by Shieva, by your personal story. I think so many of us can relate to so many aspects. So thank you. So I like to say I'm a recovering health insurance executive. I spent almost a decade marketing in marketing leadership roles in health insurance. And so I'm here today to dig into the insurance coverage issues and the role that employers play or could play, should play in enabling access to obesity treatment. So on the next slide, I don't need to rehash. The doctors have explained, the wide range of treatments that are available, which is, quite amazing in this day and age, how medical advances are bringing new options to the table. It's wonderful. With those new options, though, comes medical expense. And so I think there is a tricky dynamic here. So there's obviously growing recognition and the movement to recognize obesity as a medical condition, and certainly growing recognition of the multitude of medical complications, medical and mental health complications that can be associated with overweight and obesity. And so it stands to reason that insurers, anyone who cares about medical expense, would want to reduce those costs by treating those conditions or treating the underlying cause of those conditions. However, something that I think people don't always recognize or understand about health insurance is that some of the costs or some of the problems that cost insurance companies money take a long time to build and grow and manifest. And so if you have, for example, pre-diabetes, that is very likely to, or that really could turn into a more serious condition that costs a lot of money to the health insurance company, but that might happen over time. Whereas if they approve surgery or a medication for you, especially a new medication, they're paying money now. And so there is a time horizon to how insurance companies think about the cost benefit equation. So, yes, obesity causes complications that the insurers might want to reduce, should want to reduce, but the cost burden on the insurance is kind of immediate if you take a medication. So not surprisingly, the insurance companies use and if you have health insurance and you've ever tried to seek anything other than sort of bread and butter primary care, you've probably encountered some number of these insurance tactics. So they, especially for the more expensive procedures or medications, it's very common to need to go through prior authorization, which just means that the insurance company reviews the case, reviews your request or your provider's request for that treatment, and decides if they think it's worthy, essentially, and decides whether or not to cover it. Even if they cover it, they may or may not cover it from the provider, prescriber at the facility you want to get it. They may require you to fail something else first or prove that you've tried something else and it hasn't fully worked. That's step therapy, commonly used as a term in medication. So try the generic drug first. If it doesn't work, we'll consider the brand name, which is typically more expensive. But in obesity medicine or obesity treatment, it also is sort of the same concept as first try diet and exercise, and then we'll see if you are qualified or eligible for surgery, things like that. Even if insurance does cover a medication, let's say, they might limit how much supply you can get at one time, and then they will again, this is not news. You have cost sharing for the most part of, any more expensive medication, typically you're going to pay for at least some part of that medication. That's called cost sharing. And the insurance plan can sort of jigger it. So it's more or less depending on how much they want to sort of allow unfettered access to that medication. So they have this toolbox of barriers essentially, and to be fair to the insurance company, they would say they want to prevent unnecessary or inappropriate utilization, both for the protection of the consumer so that the patient doesn't get treatment that they don't need or shouldn't have, and also to be good stewards of financial resources. And I think the most important criteria that insurers will typically use and cite is medical necessity. And that is often the problem or the root of a problem with access in weight loss or obesity treatment, because for a long time and still today, it can often be considered cosmetic. And there's nothing to an insurer, there's nothing medically necessary about a cosmetic procedure or cosmetic treatment. So that can make it really tough. There are other requirements. Obviously, we've talked about some of the folks have already talked about needing to demonstrate behavior change or psychological exam. I think that is something that goes along with surgery. And then you have to have, right now, we're very aware that you have to have, that if you have diabetes, it's a lot easier to access an AOM or a anti-obesity medication. So there's the ways that insurers can limit access and the reasons or the basis for those limitations. And when you're trying to get coverage, these either side of this or both together can create real barriers. But if we go to the next slide, it sort of points to why it is so important for health insurers to cover. I'm going to focus, of course, there's this wide range of treatments, and I want to give them their due. At the same time, I think, AOMs are hot. Everyone's talking about them. Many people are taking them. Celebrities are espousing them and so forth. So let's focus a little bit on anti-obesity medications. They are expensive. If they're not covered by insurance, the average out-of-pocket price or cost per month, it can be about $1,000. It can be more, it can be less. But just as a round number, think $1,000. And for most people, most average people, that puts them out of reach. This slide just provides some data about the distribution of cost sharing that people have, or costs that people are paying. And it does show that, excuse me, that, you know, almost half of the people who are on a GLP-1 or a anti-obesity medication are paying $100 per month or more, and 10% are paying $750 or more. So again, that may or may not seem like a lot depending on your financial situation, but for a lot of people, it's a lot and it's too much. So on the next slide, we can see that we can introduce insurance and what happens when we ask. So Kaiser Family Foundation does wonderful healthcare research and health insurance research, and they surveyed people taking AOMs and found that overall more than half reported that they were sorry, I jumped a slide, but this one talks about the hardship that people feel due to the cost of the medications. I could probably show you a similar slide for sort of every aspect of healthcare. The cost of healthcare creates obstacles for, you know, a large swath of the American population. Anti-obesity medications in particular are difficult to afford for a majority of people. What is crazy to me, yes, I did include this on the insurance side of things here, is that there's actually really no difference between whether you feel a hardship because of the cost of your medications or not. Insurance makes no difference. And that is something is really wrong. If you have insurance and it's covering your medication and you're still feeling the hardship, that means insurance is not covering enough to make these medications easily accessible or affordable. On the next slide is where I can show you that most people are paying for some or all of their medication. So only about a quarter of people in this survey had full coverage from their insurance. And about 20%, 1 in 5, were paying for the whole cost on their own. And that vast middle is getting some help from insurance, but still, as I showed you on the prior slide, it's not really enough for a lot of people to feel it's easy to afford. So that's all to say, the cost of these medications in particular is a problem for a lot of people, and insurance is not helping that much. Helps for sure, but not that much. So on the next slide, I think I've already talked a bit about the barriers that insurers, excuse me, impose, and I've talked about why. But I think that, as I said, the number one thing is prior authorization. And some of the kind of tricks about, you know, have you tried this and failed, or you can get it, but with these limitations or these restrictions or these costs, as we've talked about. And I've been talking to some healthcare providers about what they see in this space, and they told me both you can not lose enough weight. So you can the insurer might approve a medication and then say, oh, you're not losing weight fast enough, or you're not losing enough weight. That renders this medication a failure. You have failed this treatment, and withdraw approval. And the other thing that I heard is the opposite. So it works, you lose all the weight you need to, you're in maintenance mode, and now you no longer meet a weight requirement for the medication, for the insurance weight requirement, and they can withdraw approval. So that is, completely upside down and backwards, of course. If it's working, and I'm not a doctor, I'm not a clinician, but everything I understand is that there's a reasonable expectation that that these are long-term treatments and that people will need to stay on these meds for a long time to maintain weight loss. And so if it works and then you can be booted off, that seems backwards. That seems really counter. And I believe, I hope that those kind of wrinkles will work their way out of the system. But for now, those are the kinds of things that, at least anecdotally, providers are reporting. I think the other thing that can happen to disrupt coverage or to disrupt access is a new plan year kicks in, and the plan design changes, or you switch jobs, or your spouse or your partner switches jobs, and you wind up on a different insurance plan, and the whole cycle begins again. Typically, the prior authorization approval you had last plan year rarely carries over into this plan year. And so there can be a stopping and starting of medications that I think is again, I'm not a clinician, but I think it's not clinically recommended. And of course, financially and psychologically, it can be really harmful, I think, to patients. So just on my last slide, I just wanted to go a little bit deeper into the employer, kind of what's the lay of the land with employers. And in fact, of course, many are covering a GLP-1 or an anti-obesity medication for diabetes, but only about a quarter say they're covering these drugs for weight loss. Now, another chunk, or 13% in one survey, say they're considering adding coverage for weight loss, which is positive, but that will still leave, even if every one of those employers adds coverage for weight loss, that's still going to leave the majority of employees uncovered. And I just wanted to point out that there is a lot of data on the cost, both direct cost and indirect cost of obesity in the workplace or on the workforce. So their direct medical costs, one statistic I found said that women with obesity have $5,000 of direct medical costs each year. That's a lot. Again, most people don't have that. The other statistic I think is really notable, and I hope employers really pay attention to, is that employees with obesity have nearly three times the medical spending or the healthcare spending of employees without obesity. So again, if you can quantify, and we can, the cost of obesity in the workforce, then it should be really clear the economic benefit, not to mention the physical and psychological mental health benefits of enabling access to treatment, but just the cold hard economic benefit to employers is very clear. The other thing is there's, again, lots of data on when people are generally sick, what it does to their productivity, their attendance at work, and the same, those kind of statistics or condition or dynamics are at work with obesity. So employees with obesity miss 3 more days of work per year than employees without obesity. And that may not seem like a lot, but if you're an employer with a lot of employees and you need your workforce present and productive, that can add up to a lot of lost productivity. In fact, the estimate is somewhere around $300 to $500 of lost productivity per employee with obesity. So there are a lot of reasons, clinically, medically, psychologically, to cover weight loss treatments. It's certainly good for the employee to have that access, but it's also costing employers a lot to not provide that access. So I just want to leave us with a consideration of the cost benefit that employers and insurers should be contemplating.
Thank you so much, Deb. That was a fabulous landscape analysis of everything going on in the coverage space. So thank you. I'm hoping we could do just a few minutes of Q&A with our panelists before we wrap up today. And I think I'll start with Deb since you were just speaking. I think you did a really nice job talking about how employers benefit from covering obesity care. Do you have advice for someone who wants to discuss obesity care benefits with their employer, but maybe is a little bit afraid to or hesitant to do that?
Sure, absolutely. And we have some great resources on healthywomen.org. So I hope folks will find those as well. But I encourage people to really read their policy, read the member handbook, try to figure out what is covered. You might be surprised. There might be things you're entitled to that you're not maybe getting. So first find out what is covered and what is not covered and how are things covered. So do you have access but at a very high cost sharing or something like that? And then arm yourself with very specific details about the treatment you need, the treatment you're on, or the treatment you want to be on. So if you are taking or want to be taking a medication, which one, at what dose, in what modality? Because each drug, each dose, pill or injection, they all can have different costs associated and different coverage. So get the details together, calculate the direct cost to you. So you have been paying, if you're a woman with obesity, living with obesity, you've probably had medical costs that are related or adjacent to the condition of obesity. What are those costs? And then try to think in terms of the indirect costs, both to you and to your employer. And then go to your HR person, your benefits representative, and say, I have this condition. I need this treatment. I have a medical provider or a healthcare provider saying I would benefit from this treatment or this combination of treatments. But as I read our policy, it's not covered, or it's not covered at a cost that I can afford. I would like to ask for an exception or help paying for these costs, or help accessing the medications, or I would like your help to encourage the approval of my prior authorization request. And there are a lot of rules governing what insurance can and can't do, and the policy can't change overnight. There are a lot of restrictions, but your HR department, your employer, has discretion over how can they help you. They also are buying the benefits for the company, so they're deciding in conjunction perhaps with the insurer, but they are still the client of that insurer when it's a group plan. So they have a lot of right to speak up and request or nudge towards certain kinds of coverage. So again, that might take a while, and you might need something more immediate, like an exception or some other kind of benefit that they might be able to provide outside of the health insurance coverage. But it's the employer who decides ultimately what is covered above the basic requirements. So you should, by all means, prepare for that conversation, be willing to have that conversation, and consider that you might be helping yourself. You're certainly helping others who also need access to these treatments.
I love that piece of it. Thanks, Deb. You spoke about the stigma that women might face, women who are living with obesity. I wanted to ask Shieva, as she's both a patient and a physician, what advice do you have for women who are living with obesity when they face stigma from their healthcare providers?
Well, first of all, I apologize for everyone who faces, stigma nationally, but certainly by their healthcare providers, because I think that's sad, right? And it's inappropriate for anyone to treat anyone badly for anything that they are struggling with. That said, and I hear this a lot because I'm pretty active on social media, I think there's a really strong through line of anger and animosity towards doctors and PAs and nurse practitioners for even asking about weight or recording BMI, right? Like we hear a lot of people saying, you have every right as the patient to just decline your weight. Can you believe they asked about your weight? Can you believe they recorded your BMI? And what I try to really tell people is most of us as doctors don't want to record your BMI. I care about people's weight, but I care about it in a more organic sense. I don't care about the number on the scale. I say to my patients all the time, even when they're pregnant, where we have to weigh them every single time, you tell me your weight if you want. It's fine with me. Like most women know their weight. I don't know a woman who does not know her weight, right? So the weight in my office is not material. How they're coping psychologically and physically with whatever body frame they are in is important to us because it has medical implications. So we do need to know their general weight and their general eating habits so that we can help inform them as to what risks they might incur or ways to help. But the truth is, the only reason most of us, at least, are recording their weight is because the insurance companies dictate it to us. And if we don't record their weight or BMI, the insurance companies, and Deb, correct me if I'm wrong, but I've seen this happen in my office, can actually take back our reimbursements years later. They can actually audit our charts and say, we looked at these 20 charts and you didn't record BMI, so we're going to remove a certain amount from all of your annual exam reimbursements for the last 5 years, for example. So again, I think that we have this dichotomy. Patients are angry at doctors for recording BMI. Most doctors don't want to record BMI. So I think they need to understand that. On the flip side, we do have a lot of doctors who are, some mean to and some don't mean to, but they lead with shame. They lead with verbiage that is not very sensitive. They use terms like obesity really readily without kind of discussing the nuances of it. They'll talk about BMI. They'll also kind of just talk about weight as if a woman, again, doesn't know her weight or doesn't know what she's doing. I mean, in fact, I have patients who occasionally will say, do you think I need to lose weight? Do you think I need to do, X, Y, Z? And I always joke like, I'm pretty sure you know already. And if you want me to talk to you about it, I am more than willing to talk about it. But for me to have a patient come in who's 250 pounds and 5'3" and act or behave as if she doesn't know is just unfair. That is being an arrogant physician who feels like I have to, cross my T's and dot my I's. So my best advice to patients, sadly, and this comes from a place of privilege, obviously, of being able to have the time to research doctors and meet doctors and actually find new doctors. But my best advice is find a doctor with whom you feel aligned and with whom you feel comfortable talking about everything, by the way. It could be sexuality, it could be weight, it could be, your favorite baseball team. Like, you should find people that align with you, not because you want someone to yes you. I mean, the ideal is you have someone who you can talk openly with without shame, but who will also help you with the very real fact that heavier bodies can potentially have medical risk factors, right? Like, I know that many of my ailments were a result of my weight. As I said before, I don't feel guilty about it. I don't feel bad about it. I did the best with what I could, but I also needed doctors who were going to be gracious, but also honest. My bariatric surgeon was so wonderful and so honest with me. Whereas a cardiologist I saw who wanted to be gracious, but couldn't admit to me about my weight. I had said to him, don't you think all these issues are just because I'm really heavy? And he was like, well, I mean, I think, and that poor thing, I mean, he was a fit man. He went the opposite direction. He was so wanting to acquiesce and make me feel okay that he couldn't really help me. So I think you need to find someone who doesn't treat you badly, but you also have to be realistic. Like, we could say that we want confidence at all weights, and I want that more than anything. I actually deeply believe that the longer and better we could encourage, especially women, to feel confident at any weight, the less weight we would actually be. Had I felt so confident at 130 to 150, I wouldn't have gone into 250. I mean, and this is something I'm now really dealing with my 13-year-old girl, who, just like her mom, loves her food, but I refuse to treat it with shame. I know that the best thing I can do is make sure she feels really strong and confident so that she doesn't let the weight become an issue that just escalates. So again, my sad but best piece of advice is be forgiving of the doctors. We don't weigh you because we want to. We often weigh you because we have to. Yell at the insurance companies, because I hate to say that, but they are the crux of evil for all of this. And unfortunately, you have to leave doctors if they are not helping you. And that's not always easy because we have medical deserts. We have, lack of access with insurance, with time, with a lot of different parts of our medical system that are broken. But it's kind of the only option you have right now.
Thank you. Priya, one question for you. I was wondering if you could speak to the impact of obesity on women of color specifically.
Absolutely. So, we know that there's a significant contribution of racial and ethnic disparities when it comes to the prevalence of obesity. And especially when we talk about women and then women of color, right? So, for women, if we look at some of the federal data that we have back from 2017, 2018, from age 20 up to 60 and over, that's about 40% across each decade of obesity prevalence. And if we look into a subset of data, around 2015 to 2017, we have data that shows that non-Hispanic Black individuals have a higher obesity prevalence than other individuals, and following them is Hispanic individuals, right? So we do have evidence that they have higher rates of obesity prevalence, and that's from a lot of the disparities the communities may face. I know personally, I came into this field because as a women of from a minority community, I saw minority communities being affected by a lot of chronic diseases, including type 2 diabetes, whether that's living with obesity or overweight. And I wanted to help contribute to combat that. I think as people from minority communities, I think it's extremely important to take into consideration the risk factors that you're potentially living with, knowing your family history, taking into consideration things like heart disease, high blood pressure, high cholesterol, pre-diabetes, and making it very known to your physician that you're concerned about either the development of these conditions, having subsets of these conditions, and making sure, like Dr. Ghofrany was saying, that they're aligned with your goals. It's very important to make your physician aware of your goals and also the background which you're coming with, right? Which includes your health history, but also your family health history.
Thank you so much. I'm going to ask a last question for whomever would like to take it. But what can women do to advocate for better insurance coverage of obesity care with their policymakers, with their employers? Do you have any advice?
I think it's probably important to start on multiple levels, right? So just speaking to other individuals, maybe at your job, even about if they're receptive to the conversation about obesity as a disease, what they've faced, or if they're living with overweight, or if they're struggling with other weight-related conditions. I think that's a first step. I think then going to your HR or your employer who decides your benefits, right, as a second step, then maybe moving a step higher, right? Speaking to state policymakers, whether that's the governor, whether that's a legislator, whether that's a state benefit employee director, right? So it's really important to get onto that level as well from a grassroots perspective, and then also engaging with your local community partnerships, right? That's a huge essence of why we're all here today, but I think also reaching out to other organizations that may be active in your area, whether that's Obesity Action Coalition or any other organization which may be very involved in making some of the state legislation happen. And you can also be on the lookout for other coalition meetings, right? There are employer coalition meetings that happen, benefit meetings that happen. You can get involved in some of those arenas. So I think if you want to take it from a stepwise approach, it can be something as simple yet significant as speaking to somebody who's a colleague, who's a friend, who's a family member about the importance of getting this coverage, and then working together up from there, maybe starting with a small microcosm like your work community, building up to a state level, and then going up from there.
I would say that keep in mind that the more coverage or the more things that are covered, the more it costs insurance companies. And so they don't typically add coverage voluntarily or willingly or eagerly, but they do respond to pressure from the public, from regulators, from employers. And so absolutely all of the above. As patients, as individual women, we can and should tell our stories, speak up, use our voice, and ask for what we need. And we may not get it right away, but if we all do that, that is the only thing that really does ultimately make these kind of changes.
Well, thank you so much to all of our panelists. I think that that concludes our briefing for today. So thank you for joining us today, our panelists. Thank you to the audience for joining us today. And thank you to the Alliance for Women's Health and Prevention's Everybody Covered campaign for their financial support of today's webinar. And thank you also to Healthy Women for bringing us together today. I'd encourage everyone watching to visit Healthy Women's website for more information and ways that you can take action to ensure every woman living with obesity has access to the care that they need. So thank you so much, and wishing you a wonderful rest of your day.